So droplet. Droplet is 5 micrometers, is a droplet which is in the nasopharynx or laryngopharynx. That does not go to the lower respiratory tract unless if it is less than 5 micrometers. When you sneeze or cough, depending on the size of your droplet, it does get the distance it has to go. Is it the projectiles? You've got to look at the force of the cough and the projectile speed and the distance it would cover. So normally if it's a 5 micrometer, they say they do not go more than 1 meter. If it's a less than 5 micrometers, it could go longer. So hence the social distancing is made at 2 meters, 6 feet. You understand that. So we keep on saying these terms, but we got to understand the 5 micrometer is the sort of the ballpark figure to understand. If it's less than 5 micrometers, you can go to the lower respiratory tract. So you now know the social distancing policy of 2 meters apart. The next thing I also want to touch is about the understanding of the word the coronavirus. The coronavirus, there are 6 types of basic coronavirus before this COVID-19 came into existence. There are 2 alphas and 2 betas, the first 2. That is dormant, doesn't cause a problem, it doesn't cause you any diseases. It is existing and it has been always been existing. Comes and goes like the flu or etc. They are the 229E, which is an alpha coronavirus. Then the next one is NL63, which is again an alpha coronavirus. Then we have OC43, which is a beta coronavirus, and HKU1, which is a beta coronavirus. These are the dormant buddies, they're fine. Now, from there it came up the 3 types which started to get into difficulty to us. They are the MERS, Middle Eastern Respiratory Distress Syndrome or respiratory disease, CoV-1, which is a beta. Then you have the SARS-CoV, serious acute respiratory distress syndrome. CoV is a beta virus. That's also pretty much bad affected us. Now there are 2 alphas and 4 betas. 2 betas bad and 2 betas okay. So MCQ comes, you must be able to say the 2 betas are the MERS is a beta coronavirus and also SARS-CoV is also beta coronavirus. Done. Spot on. Let's go to the SARS-CoV-2. That's what is called the novel coronavirus. So that's has got 3 strains. Important for you to understand. Strain A, strain B, and strain C. That's all. Done. So far. The scientists and experts might come up to say that there are 5 strains, 6 strains. No, at the moment it's 3. Strain A is the one which was in Wuhan, which was in bats. Now, that strain is the one they say the outbreak, the root of the outbreak is the one went to Australia and United States, so the America. The strain B, which is also from Wuhan, which is a mutate slowly within China, but it started to mutate rapidly outside China. That's a strain B. Then the strain C is only one differentiated, is a daughter from strain B, is the strain C with one mutation, and that is the one found its way to Europe via Singapore. So if the MCQ asks, is a one differentiation, just say yes, done. And the A. So thereby you would see some of the world leaders today would be using term that where it came from. And they might even give a term as whatever the term they want to give. That is because this is the pattern or the distribution of the strains. And another, I'm going to give another way of remembering certain percentages. I think the coronavirus, they say is 5 to 10% is the transmission and people affected. Maybe we do not know preclinical and subclinical presentations and etc. Yet we are still on early stages to make that as a policy within our system. But I think looking at various factors and looking at the figures, I think 2% is easy to remember as a student, and then you can start to read to see whether it's 5%, 10%. 2% of the people who get infected, those are the one within that 2% of get infected. Out of the 2% would get admitted. They are not the one which end up in the ICU or ITU or serious care plan. They are the one who would have to be admitted with the COVID-19 to be treated in the hospital, the one who enters. So the 2% of the 2% gets entered into the hospital. They are so if there are 100, 4 people, within the 4 people, 2 are really would get admitted into the hospital to be treated. But they are not the one going into the criteria to be admitted into the intensive care treatment, the ICU, ITU, which Professor Tahir Akhtar spoke in detail. Now, out of the 2% who are admitted, who are serious, are being admitted and treated, but they are not in the ICU, ITU, out of that, the 0.2% might end up in the ICU or ITU to have a CPAP or to be have interventional ventilation, which is absolutely, it's quite very serious. Our colleagues, Professor Anand Kumar, Professor Sampath Kumar, Professor Tahir Akhtar, many of them, Sudarshan, and quite a lot of the consultants have been very busy, and the intense busy. These are not the normal busy, it's intense. It's a life and death situation of managing patients under a very tight regulated protocols and tough management. So the 2% rule, if you remember as a student, it's easy to understand. It can go up depending on the periodicity or the infective status, and they get admitted into the various levels into the acute COVID-19 ward. The another place I want you all to understand about the 2% is the way that you remember the appendicitis. Every layman, everyone knows about appendix. If you do not know appendix, you're not a doctor. If you do not know about the central nervous system or all the cranial nerves, 1 to 12, even at 3 a.m., then you cannot be a doctor. You must know 1 to 12, you must slip it and flip it, and you must tell all the 12 cranial nerves, and you should be able to examine all the 12 cranial nerves, closing your eyes, because there is a bread and butter of medicine. So the 2% rule applies, and the 2% is the appendix. And the appendicitis is not a part of the COVID, but it's something to relate for you to remember. 2% of the appendix is retrocecal, they're not anti-retrocecal. 2% of the population do get appendix, and 2% gets into the complication of gangrenes, and you need to go into very various can have a septicemia, etc. And 2% would have dual coverings, the walls of the appendix. They can have vecus diverticulum, or they can have columnar normal epithelium. So the 2% rule is something for you to easy to remember, and make sure that you remember that all the time. I like to now talk about some of the other terminologies, very important as well. The important part of the entry of this particular organism, COVID-19, is angiotensin enzyme receptor 2. So which is basically, it's in many parts of the body. I'm making it very simple, no complex here. Many parts of the body. It is found mainly in abundant in the lungs, in the respiratory system. You must also must know, there's no excuse on that, it's the oropharynx, the borders of the oropharynx, the boundaries, and nasopharynx. And you must also know what opens into the nasopharynx, very vital, very important. The anatomy should run through fast. And the laryngopharynx, where the folds, the true vocal cords, the function, etc. All the nerve supply, recurrent laryngeal nerves, supply of the arteries. Now that the COVID has come, it might be there for some time, as the experts say. So this system you must know by heart, the anatomy, the entire bronchus, right and the left, the carina, the right and the left, the bronchus, and where it bifurcates, the 3 lobes on the right, 2 lobes on the left, and 14 segments and 10 segments you must know by heart, because these are very vital. And the alveoli membrane, there are some questions on that. There is no excuse on that. You would have also now remember one thing I want to say about, before I go into the angiotensin to receptors is about the CT and the chest. As Professor Godwin Simon explained in his lecture, that there's a protocol. You have a chest examination, early pickups, or doubtful that this could be a COVID or not. They have a protocol to have a high resolution CT where they look for ground glass appearance. It's very important for you to know what a ground glass appearance is. There's questions coming on that. And also you must know about the CT and the role of CT and what this all means. AC2 angiotensin converting enzyme 2 receptor is an mRNA receptor, which is polypeptide, and it's how it works. Abundant in the lungs. I'm not sure about the percentage, about 85% of it is in the lungs. It's in the alveoli membrane. You find them in the veins. You also find them in the arterioles, where that in the smooth muscle it causes the vasoconstriction, where that it is again used as part of the management of the hypertension. Then you also find them in the brain. It's very important here now that as soon as it's a brain, you must know the BBB, blood-brain barrier, COVID-19 is crossing. Now it goes, the cerebral cortices, it's there, you find these AC2 inhibitors in the brainstem and in the striatum. There that you find the olfactory cortex and olfactory lobes. So hence, these patients do have anosmia and dysphagia, that is distorted smell. So American College of ENT head and neck surgeon, otolaryngologist, they made this as a significant symptom of patients having anosmia and loss of taste as part of the COVID. That's important for you to understand. You got to understand. No escape on that. So these terms, what I have told you, would be coming in part of the questions. It's again